like to be the first to welcome you to our webinar, Navigating Risk Adjustment Headwinds in 2017. My name is Sean Forster, and I will be the moderator for today's discussion. Before we get to the presentation, I do have a few housekeeping items. During the presentation, all participants will be in listen-only mode, so no need to put your ringer on silent. Also, today's webinar is being recorded and will be made available on our website, cohealthanalytics.com, by the end of the week. Although lines are muted, we do encourage you to ask questions during today's presentations. To do so, please submit your questions using the question windows located on the right side of your screen in the GoToWebinar module. Type your question into the box, click Send, and it will be sent directly to a meeting organizer to queue for the Q&A session we will host at the end of the hour. Should you encounter any technical difficulties during the webinar, please also utilize the questions window to describe your issue, and one of our support staff will follow up with you to troubleshoot. Throughout the webinar, we will also have a series of polling questions to gather your input. When we reach those points, I'll read off the question, and you'll be able to select from a list of options. With that, I invite you to sit back, relax, and enjoy today's presentation. I'm happy to introduce our speaker today, Pam Glickman, who brings with her more than 25 years of experience in healthcare. Prior to joining the CO team, Pam was co-founder and chief products officer of Clear Vision Information Systems, a provider of software and services to optimize care and revenue for plans and providers across the country. Pam has served in leadership and oversight roles for Blue Shield of California, Blue Cross of California, Cedars-Sinai Medical Center, and Northridge Hospital. With expertise in system development, data analytics, and risk adjustment strategies, Pam is a recognized industry expert. She has been active in the Industry Collaborative Effort, or ICE, since its inception in 1998, and has co-chaired the ICE Risk Adjustment, Data Acquisition, and Reporting team for several years. In her role as CO, Pam is actively engaged in the day-to-day operations of the Westlake Village office, supporting product ideation and innovation strategy, as well as solution and service design. So today's discussion is focused on the coming risk adjustment headwinds in 2017 and what your organization can do about them. We'll spend the first part of our time together describing just what they are. Some of these headwinds, like our first topic of the shift towards EDPS data, you may be experiencing already. Others that we'll cover later in the presentation, like the potential use of vouchers in Medicare, are further off onto the horizon. The second half of the presentation will be filled with tips, case studies, and some examples of what you can do to optimize your risk adjustment programs. And any remaining time we have will be dedicated to a question and answer period. And with that, I'll step aside and turn things over to our speaker, who's going to start by talking about the transition to EDPS data. Pam?
Thank you, Sean, and hello, everyone. So the continued shift in counter data, or like I like to say, can this get any more complicated? So first of all, let's talk about the differences, RAPS and EDPS. And I look at this like RAPS being like horseshoes and EDPS being like golf. And what I mean is RAPS is a format is very basic. It's human readable, few rules and 6 data elements, where EDPS is sort of like golf. It's a lot more complicated. You have to get it exact, and there's many rules, and it is totally non-human readable. So let's first take a look at what is the difference in format, just how different they are, and why you need to know the difference in the potential impact on your reimbursement. Here we illustrate, and this is just one line of RAPS, and not even the equivalent information in an EDPS data format. So with that one line in the RAPS data, you're able to take a look at the record ID, transaction date, file type, submitter ID, is it prod or test, what diagnosis are you using, ICD-9 or 10. All of that is contained in that one line. On the bottom, it's very, very different. This is not, what I say, not even the equivalent. It's the equivalent of the first line, the AAA record in a RAPS, but you can see that the two have absolutely nothing in common. On the RAPS data, if you know what position your information is in, you can easily discern it. There's no way that you can do that on the bottom. So let's talk about why it is critical that you understand these differences and make sure that you do EDPS as complete and correct as possible. We're quickly moving from, we're quickly approaching the time when all risk adjustment payment will be accomplished using only EDPS data. And although CMS has been collecting this data for over 5 years, it's only since payment year 15 that it's being used to calculate the CMS-HCC payment. Initially, for the 15 payment year, all EDPS HCC data would be additive. So whatever you got from RAPS data, if you got something additional from EDPS data, it would be additive. And it's now January 17. This is for 14 dates of service, 15 payment year. January 17, we just got information about what that add was to our payment. CMS did the initial final payment for 15 in July of 16, and again, 17 or the final, they call it the second final, has just been incorporated this month. As you can see for 16, it's a 10/90 split, 10% EDPS, and it will be in the final settlement for payment year 16, which will be somewhere past May. Well, it will be probably much delayed, just as 15 is, and the reason being, we'll get to this later, is that they're changing the final sweep dates for EDPS submissions. This current payment year, the 25/75 split, was meant to go into effect mid-year, but recent information is that it will take place in the final again. So encounter data as a diagnosis source, CMS, here's the blend timeline with CMS rapidly approaching 100% EDPS. Now, CMS notes that encounter data submission rates have steadily increased and error rates have decreased. So they expect this trend to continue to improve as more experience is gained and the data stabilizes. And given this, CMS plans to increase the weighting over the next couple of years, as I said, to go to a full EDPS in 2020. Information to the plans and hopefully flow to the providers on what encounter data has been will be accepted for risk. Here's a little timeline about this. CMS released the first MAO 004, which we find is analogous to a RAPS return file, dating back to 2014 in December of 15. And as we all know, there were many issues with that data. They corrected all of this data supposedly in the third weekend of October of 16, again, retro to January 2014. And as recent as the November 2016 EDPS RAPS user group, we know there are still issues, but we don't have a timeline for correction of those. So it's important to reconcile RAPS submissions to determine the ultimate payments for 15 and 16, but unfortunately, we won't be able to accomplish that as an industry until we have confidence in the MAO 004s. It's clear now that organizations with a poor handle on EDPS data will struggle to compete, as their reimbursement payments will suffer as we move toward more reliance on EDPS data. Recalibration based on EDPS is also an issue, but we'll talk more about that later. There's the CCI edits that everybody must pass, which is quite a bit different than the edits on the RAPS file. But some of the benefits are, with encounter data, CMS will have a wealth of information to analyze differences in patient populations, and also this data will provide insight into value-based payments. So let's talk a little bit about the data flow. I think anyone that knows me knows that I'm all about foundational efficiency and effectiveness. If you don't have the foundation right, it doesn't matter what you put on top of it, eventually it'll crumble. So for RAPS data, the top line, RAPS are filtered by the health plan. When they filter it, put it into RAPS, send it to CMS, they have a one-day turnaround into what is accepted and what is rejected and the rejection reason. On the other hand, EDPS, the plans must send everything to CMS. It's filtered by CMS, and there's still no definitive results or reporting on what got filtered through, as the MAO4s are still not correct. And it's a two-stop method or two-step method rather than one step. You have an MAO 002 return file, which tells you of the EDPS what made it through the initial CCI edits, i.e. claim type and edits. And then you have a 04 file, which tells you of those that passed into the front door, as I call it. The 04 shows you what went on to be included for risk adjustment. In either case, the provider and plan need feedback reporting at every stage to ensure all rejects are addressed. So what have we learned to date? Getting consistency and alignment between RAPS and EDPS is not a straightforward process. RAPS we've been doing for a number of years. People have processes in place. It's a reliable and a repeatable and a predictable cycle. There's varying degrees of readiness with proactive plans investing tremendous resources to clean up their claims processing and data flow, and I'm going to use claims and encounters interchangeably here. We here at CO Health Analytics have worked with clients who have seen as little as 5 to 15% variance and as much as 40% between the two data sources. And many plans and payers are struggling a bit more on the EDPS side because it's harder to get the data through the front door. We most frequently see the degradation in EDPS scores as opposed to RAPS. Not because there's less risk adjustable codes using the CMS filtering logic, but due to the added complexity and often all diagnosis codes not getting into CMS. For example, here's one example that's quite interesting. On the RAP side, if you need to add diagnosis, you add diagnosis. As long as it's not the same diagnosis you had before, it'll get captured for that member for that data service and payment period. And if you have to replace something, you would send a delete for a diagnosis and send another diagnosis. On the EDPS side, if you are doing a replacement claim, say you sent your original claim in, you had 3 diagnoses that were accepted, but you had to replace it because you have 5 now. And you choose to do the replacement methodology rather than the like deleting and resending. The first thing CMS does is they overlay that original claim with your new one, and then they edit it. So should your replacement claim error out, you've not only lost those additional 2, you've lost the original 3 because nothing went through. It's an overlay, then an edit. So interesting stuff, and we all need to be aware of this. We all need to be aware that EDPS is a much more complicated beast.
Okay. Thank you, Pam. That actually brings us to our first poll question of the day. So if we go ahead and launch the poll, please. Okay, so we know that different organizations are in different stages of adapting and refreshing their risk adjustment programs to incorporate this new blended data source. So our question is this: how far along is your organization in implementing the changes needed to support the EDPS and RAPS blend? Are you all done and ready for the next change, the 25%? About 75% of the way there, progressed pretty far in your project, still have some final T's to cross and I's to dot. Halfway point, just starting, or are you sort of maybe haven't quite started yet and are about still hoping for CMS to change their mind? So give folks just a few seconds here to submit their answers, and then we will share the results. Looks like about half of the people have responded. If we go ahead and close the poll, please, and let's share results. So it looks like about 40% have made a good amount of progress and consider themselves about 75% of the way there. 15 have already completed their project, and the remainder are either just started or haven't started yet. Thank you, everyone, for participating in the poll. We'll move on with our presentation. Okay.
Thanks, Sean. So let's talk a little about some information that has come from HPMS rather rapidly. First of all, the CMS has released several months ago, and again, another update on their February software release. Supplemental data on the 04 has to do with additional CPT and HCPCS, which we will discuss in a little more detail later. The MOR maintenance for 17 has to do with record type D, which is the mechanism they're using to tell plans what HCCs came from encounter data, as opposed to record type C, which is what came from RAPs. And then, of course, changes for Medicare reporting on the daily transaction reply report and the MMR. Of course, these are all geared for the health plans. And that has to do with the dual versus full eligible on Medicaid, because tables for risk are predicated on those designations. We also have, as we mentioned earlier, the final 15 risk adjustment, the second iteration, which reflects the EDPS impact for dates of service in 14, is out with the January 2017 MMR. Final run submission dates, no changes on the RAPs. They're still January 31st every year, but EDPS for the same date of service year has been moved to May 1st, and we think that that will be the date for the next few upcoming years. The mid-year run, as we mentioned earlier, no blending for EDPS for mid-year with 17. It will be included in the final. So let's talk about the impact to health plans and providers as a result of the blend. Given everything, we're going to keep the risk score at 100% for each one. So if your EDPS and RAP score are equal, take a look at column 1, both raw EDPS and RAPs at 90-10 blend, the total is 1.090, and if your EDPS score and your RAP score are 100% the same, you're going to have no impact to your dollars. $981, I think we're using a $900 average county rate. So in other words, if both EDPS and RAPs had a calculated risk score of 1.090 and the blending had no impact on the final RAP score, your PMPM is 981. However, let's move to column 2. Column 2, and this is at a 90-10 blend, if your EDPS score is 10% lower, so your total of your EDPS score is 10% lower than your RAP score, you can see the degradation in payment. The RAP score is the same. I mean, it's 981, but we're going to take the 90% of that. Your EDPS score, however, is lower by 10%. Your total is 1.090, and you're going to lose $10 PMPM. Moving on to 25 and 40, you can see the degradation in payment as your EDPS score as a percent of the RAP score continues to decrease. This is 90-10. Now, we're in a 25-75% year. Holding everything equal, in other words, 100% on each side still equals 1.090, so you're 981. If your EDPS score is 10% lower in a 75-25% world, you have an additional $15 or a total of $25 PMPM degradation because your EDPS score is, put another way, your EDPS score is only 90% of what your RAP score is. And you follow that down, your 25 and 40%, you can lose up to $100 PMPM if your EDPS score is 40% lower than your RAP score. Now, we chose this range for a reason. So 40% is not unusual if you're not actively addressing the issue. And less than 10% is not unusual for organizations who have focused on aligning these two data sources. So we picked these ranges for a reason. It's what we see in the real world. People that are under 10% or even very close to 100%, i.e., within 97, 98, 99% of the two scores being equal, these are people who have been actively working this for 18 to 24 months, 1.5 to 2 years. So if you're just waking up about it, if you're just going, oh, I guess I better look, we'll know in a couple weeks what the blend will be for next year, and so you can extrapolate these results based on that. But seriously, we all need to take a look at this and we all need to pay attention and make sure that these two are equal.
Great, thanks, Pam. And that brings us to our second poll of the day. So if we could go ahead and launch that, please. And this is a question more if you happen to know it. We're curious from this audience collectively, sort of where do your comparison between EDPS and RAPS fall in the range of discrepancies we just went through? So this is anonymous, don't worry. If you don't know it, we do have a not sure. And maybe this is more geared towards the folks that have started to at least put some process in place and how they can improve. So it's that 85% from our last poll. So give folks just a few moments to insert their answers. Okay, let's go ahead and let's close the poll and share the results here. It looks like an overwhelming majority, nearly 75%, have the discrepancy or are not sure what their discrepancy is. And then after that, about 20% or so fall within that 10 to 25% lower scores. So maybe an opportunity to get some transparency into what their
Exactly, because that is what is going to help all of us is if every player in this game, meaning providers and plans, understand what those variances are and work together to resolve them.
Okay, back to the slides.
Okay, so now that payment isn't enough, now that an adjustment to payment based on EDPS isn't enough, let's talk a little bit about calibration. In order to understand calibration and what it means, we have to go historically back to CPT codes and where they came from. So CPT, of course, current procedural terminology, they are literally owned by the AMA, and the AMA will impose fines on you if you don't seek their permission or pay for access in some cases. Now, of course, there's huge exceptions to this if you're a provider or a plan, you're using it for payment, but anybody who wants to use or utilize CPTs in an application or anything that you intend to sell later, you have to pay a royalty to AMA. Interestingly enough, if you're NCQA certified and you use CPT codes, which you must have in order to put in the logic of NCQA, you have to pay that fee just to be able to be certified. So you pay the fee not only to NCQA, you pay fees to AMA and AHA for CPT and revenue codes. The CPT, CMS, Medicare Part B began to use CPT codes in 1983, and then as we move on to 2000, it became mandated. So interestingly enough, I believe Medicare began in 1965. So the first published CPT code listing by the AMA was in '66, right? Just following that. And there's many categories of CPT. So then you ask, why are they important? Okay, people get good at what they get paid for. So we got really good, we the Medicare Advantage industry, at collecting diagnosis because that's what drives HCC, that's what we get paid for. Fee-for-service, on the other hand, got really good at taking CPT codes, which is what you do to someone, as opposed to their health condition. So their payment is based on activities, our payment is based on health condition. So the reason this matters is that the deficiency on our side for CPT will have an impact on the perceived cost of treatment. So at a very high level, I'm not an actuary, but at a very high level, our base rates, meaning disease base rates, are calculated using fee-for-service data. Fee-for-service billings, people who bill that way and have done since the 60s, are very good at making sure that the cost associated with the disease is high, cost being based on activities, i.e. CPTs, in the case of providers. Here's an example of why that is so important for us to get it right. Traditional Medicare, let's say you had 5,000 members, 5,000 Medicare beneficiaries, and they all had ICD-10 and the code was A. I don't know what disease it is, but they all had A. And so 50,000 members had their billing to CMS with these three codes, CPT codes, and each of these codes you can see the value. and then there was another 70,000 bennies who had the same disease. They had code A, and they sent these 4 CPTs. So CMS, and I'm simplifying this tremendously, but the gist is they would take these, 120,000 members, and they look at all the costs for the disease A, and they come out with an average disease cost for code A of $1,173. That's what they say it is. On the other hand, you look at Medicare Advantage, and we have 50,000 members, we send one code. We send code 1, it's $500. We are 70,000 members, we send 2 codes, so it's, $225. So when they look at calibration based on our perceived cost data, it looks like that disease only costs $456. So get really good at sending those diagnoses in EDPS, and you have a risk score of 1.9. It won't matter much if your calculated base rate is 456 when it should have otherwise been 1,173. This is why CPT is paramount along with diagnosis. So we need to get good at this. AHIP is actually really pushing back on CMS about use of encounter data for anything because of the state that the information transparency is in. MAO4 is not right. Just getting 2015 final this month. A lot of things going on there, but we all have to work under the premise that things are moving forward as we believe, as CMS has stated this far. So imperative that we understand CPTs and have as much diligence on EDPS as a fee-for-service biller would. The trajectory. So what I like to say, let's see how much of a spin or a curveball we may be facing as we move forward. Let's talk a little bit about trajectory. So Medicare Advantage enrollment continues to grow. This is a excerpt from a New York Times article about a year ago, and at that time people were surprised at the increase in MA enrollment. A little more detail by the year. From 99 to 16, there was a little dip in mid-2000s, but there's been a steady increase in MA enrollment ever since. Perhaps more certainty in the expense versus traditional fee-for-service is the key, and why Medicare beneficiaries are moving more to HMOs. While your premiums may increase year over year, sometimes not, but they may. Sometimes you may have no additional premium, but that move will shift will likely be slower than the cost from a fee-for-service perspective. And also, there's more coverage than basic Medicare services. And one thing that is interesting to note, as we look at the distribution of enrollment in Medicare Advantage plans, so there's 69% in traditional Medicare, 31%, the bulk of that being HMO. This is how it breaks out, but there's higher coverage in the area with the predictable expenditure of the traditional HMO. And what does this imply for enrollment as we move forward into what may be uncharted territory? Let's take a look at what we think that might do as we move forward into a potential use of vouchers. So a voucher program for Medicare, and every sort of in the discussions right now, but it's not new, and it's been bantered about actually since 1984. But the thought has always been that it would drive adverse selection. So what do we mean by adverse selection? Well, what we mean is if Medicare's current fee-for-service arrangement was replaced with a voucher or a fixed contribution for each beneficiary, then it seems that Medicare beneficiaries would have an option to purchase a plan that acts like traditional Medicare or private insurance. So if you believe you're going to be really sick, then you're going to want to go for a more universally covered benefit, so your voucher dollars will go farther. So healthier beneficiaries would probably opt for traditional Medicare because they don't go to the doctor anyway. So, and who knows what will be done with whatever extra money they may have in their voucher, if you will. The potential prediction hypotheses anybody with a crystal ball. A lot of people are saying that potentially as many as 12 million more Medicare members may join MA plans. So the problem is that the consequences of adverse selection is will the funding in the future to treat a more acutely ill population that goes into MA, will that funding be commensurate with the acuity level of those members? And there's still lots of critical elements we don't know. How would they work? Would sicker patients get more money? Would age and geography be a factor? So many different things, but the perceived value to a Medicare beneficiary of joining a managed care plan parallels the perceived benefit the government would see because it's a predictability of cost. So if there's a voucher program and it doesn't change based on the Benny's acuity factor, there's more predictability in that cost as well, with the downside for the beneficiary being whatever isn't covered by the voucher, you may have to pay out of pocket. But again, none of us know how this is going to work. We're just talking about a lot of discussions that are being bantered around, a lot of what ifs, a lot of, what's going to happen when. None of it we know. Maybe we'll know more tomorrow. Who knows? So other breezes, other things to keep your eye on. Well, we already know that there's a lot of uncertainty about the repeal of ACA, although that is very likely. But the question becomes, is it going to be repeal and delay, or is it going to be repeal and replace? At the ICE annual conference in December, Jeff Grant, who is in charge of the ACA, from the CMS perspective, said that they're looking at adding drugs to the model as a predictor or indicator of diagnosis. On the Medicaid front, another quote came from John Gorman at the ICE conference. He said, the new administration sees Medicaid as a cost to be reduced, not coverage to be expanded. It may increase polarization based on decisions made within the states, and the duals and the LIS, the low-income subsidy members, may be forced into cap arrangements. On the Medicare Advantage Part D side, there's been no changes on the star ratings for about the last 3 years, but interestingly enough, and another thing that came out of that ICE conference in December, that the Part D appeals and grievances cost many plans their 4th star, which is equivalent to costing them approximately $40 to $50 million a year, because losing that 4 star, you lose any benefit you get, payment benefit from that. New administration's leniency toward antitrust, again, a Gorman prediction. It may result in 40 to 50 new health plans, including many that will be provider-led. In terms of value-based insurance design, the thought is that we're moving from a technology solution to a touch solution. And what we mean by that is 80% of services will have nothing to do with health care per se, but will be social service around obtaining that care. Getting somebody into your home to help you, getting you into the doctor or a lab test, things like that.
Great, thank you, Pam. And that brings us to our third polling question of today. And really, so let's go ahead and launch that, please. But really, we debated on whether to include this question. It's really intended to be an apolitical presentation, but ultimately we thought, it's not often that we have a cross-section of well over 100 people, all in one place from health plans and providers. So I thought we'd ask sort of the opinion of the group, sort of what would you predict happens if you could read the tea leaves or have that crystal ball, will happen to the Affordable Care Act in the near term. Keep as is, amend the existing law, repeal and replace, repeal and delay, or other. I'll give just a few moments for people to put in their thoughts. Let's go ahead and close the poll and share the results. Looks like a majority believe it will be a repeal and replace situation. And what's interesting, sort of tie between the second options of amending the existing law and repeal and delay. 3% think that they may keep as is. So.
Interesting. We do have quite a cross-section of people on the line, and just so you know, the polls are totally anonymous, so we don't even know who voted what. But we were interested to see what the feel was out there, again, because of the varied cross-section of people attending this.
Now to our second part of our presentation, which will focus on really what can be done about some of these headwinds that we're seeing.
So some tips, cases, and lessons learned. First thing we're going to talk about is optimizing your submissions. Again, I'm a very basic, very foundational person. So we're EDPS and RAP submissions, I talk about this all the time. You have, anybody, whether you're a plan, whether you're a provider, whether you're a physician, you have to, when I say provider, I mean whether you're a provider group or an individual physician, you need to understand where your data flows, where it's going. So from the provider to the billing vendor to the claim to the plan to the regulator, areas where data gets lost, claims diagnosis limitations, I think we're all familiar with that. The question is, are you familiar with that within your own organization? So do you know what's happening? If you're a provider and you're doing medical record, you're writing documentation down, does whomever in your office or a hospital, do they code it all? I think hospitals code as far as they can go. Do providers? If you are, I'm assuming everybody is all that data making it to whomever you're sending it to? If it's a vendor, is it going from the vendor to the plan? Is there a feedback loop, a control loop, so that we trace every single bit of data we have? Claims entry protocol. I have worked at many plans, and I'm surprised, and hopefully it's not like this anymore, but encounter data was in a drawer, and so, of course you had to pull that out and do something with it. Claims data, only enough CPT or diagnosis or whatever it was to get that claim through the claims payment system was entered. Now, hopefully life has changed, but within your own organization, do you know how that's happening? Whether you're a provider, whether you're a plan, whether you're an MSO, do you understand how that's happening? Another thing, encounter data. So you have to make sure that your claims department, whomever you use, internal, external, looks at your encounter claims as if it was a fee-for-service with as much attention to detail and completeness as you would a fee-for-service, because we all know at the end of the day, it's going to be utilized as a fee-for-service type claim by CMS when they start looking at how much disease treatment costs the MA industry. And again, EDI oversight, EDI vendor oversight, can't say enough about that. Feedback reports, reject claims report, volume reports. Everywhere I go, I find it surprising still that people don't know what's happening at each of those handoffs. If a MSO, IPA, provider sent 10,000 claims encounters to an EDI vendor, they have no idea how many made it through. Now, is it because they're not pulling the list down? Is it because there is no list? I don't know all the varied reasons. Some of the EDI vendors may have outdated eligibility lists, so they're not sending them through to the plan. Many reasons, and I would challenge everybody on the line to try to find out how that's happening within their organization, and I'd venture to say 98% of you would be surprised. So processes that need, process changes that you need to support the new model. So not really a new model, because version 22 has been in there a while. It's a new blend. So it's still model version 22 for Medicare Part C, but the blend is now with the data sources. And the intent of the slide is to give some guidance on things that should have changed to support the precision and continuity in the new data sources. CMS filtering logic, very similar, very likely similar to the various health plan logics. However, even if identical, the risk adjustable code output would vary from a health plan as a result of the requirements for plans to use physician specialty as a filter, while CMS is not including that specialty in its filter. So It's important for plans and providers to identify the variance in the filtered risk adjustable codes and gain insight into the payment differences that may result. Validate that all your diagnoses sent to the plan, whether on a claim or encounter or ASM, and that's a big, big deal, alternate submission method, make their way to CMS. There's a lot of providers still sending alternate submission methods. Plans, where are you putting it? Are you capturing it? Are you creating minimum data set 837s to get those sent in so that you don't lose that % of risk score that comes from your EDPS? Another issue, if you're deleting something on the RAP side, make sure you delete it on the EDPS side. We've seen that that happen as well. So now let's go talk about what happens and when you actually actively work your EDPS and RAPS discrepancies. The relative change in EDPS to RAPS when a health plan is actively working and aligning toward risk scores from 2 data sources. So when you start, when you start to work on it, you have large discrepancies. I mean, 48.8, a lot of complications on the EDPS side. So you need to have some mechanism, whether it's an application, whether it's internal, whether the plan gives it to you, something like this where you can see what % of my members have an HCC using RAPS versus EDPS. And what I mean by that is a claim or encounter that you have or your whoever you partner with has that can be filtered as if it is CMS's filtering logic. And then 04 would be, did that get verified and accepted by CMS? Now, in 15, we didn't have 04s. But if you can see the difference between RAPS and EDPS, when they first began to look and work this misalignment, was 48.8%. But after a year to a year and a half of working it, there's only 1.9% discrepancy. So 85.6 of their members, if you use the claims and you filter them using CMS's filtering logic, 85.6% have an HCC, 87.3 with RAPS. No, that could be the difference in the filtering logic with the specialty. Don't know. Then you go look at the 04s, it's 83.3. Well, you know your 04s aren't correct and they're not all in. So you could live with this and work toward getting it closer. Albeit there's always going to be a slight difference, but it gives you transparency into what's happening, not only with the data you're going to get from that data. And as we move closer and closer to 100% EDPS, this impact is going to be tremendous. So let's take a look at optimizing. Optimizing submissions in the cost world. When I say cost, I don't mean our cost. I mean the cost that CMS calculates using CPT codes that we as an industry send in. We need to apply the same level of diligence as fee-for-service. So fee-for-service billing, people who send fee-for-service claims to Medicare are very, very, very diligent. We need to have that same level of diligence. Health plans. Now, sequencing of diagnosis is not relevant for risk adjustment, but sequencing of diagnosis is extremely relevant for cost on an inpatient claim. My guess is those hospitals are sending you that information in the correct sequence to maximize reimbursement. We need to make sure that when we recreate the 837 to send to CMS, we keep that sequencing. Make sure that you, for plans that have contracts with providers who only service Medicare Advantage populations, you may need to identify them and educate them on the use of CPT and why they're so vital in addition to diagnosis codes for risk adjustment. So keep in mind, CMS will be looking at all this in a single lens. And so the funding is going to be at a fee, it always has been, whether you knew it or not. Funding for MA has always been at a fee-for-service coverage level. In other words, Medicare Advantage plans have to, at a minimum, cover what Medicare fee-for-service does, and the funding they get is at that level. The fact that we do more is a vote of confidence or a vote of accomplishment in our ability to be efficient and effective in treatment, because everything beyond Medicare fee-for-service is being funded from the savings that health plans are accomplishing by their efficiencies and their provider networks, things like that. So the additional coverage of MA is not a funded by CMS endeavor. It is an efficiency advantage. Alrighty, so prospective tactics. We've talked about this for quite a long time. Prospective, it's better to know what you need to do, go out and do it, than to look backwards and hope it was done. So the slides will be available on our website after this, and you can take a look. I don't think this is really new to anybody. Any deficiencies in any of these items is going to decrease your risk factor as well as HEDIS, and you have to balance those two tactics. First, of course, you have to go retrospective and clean it up, but our philosophy is to be prospective and give something to the physician when the member's in front of them with both deficiencies in quality and risks. So while the member's in front of them, they are able to address that. Much more efficient, less provider abrasion, and less member abrasion, because then they don't have to be asked to come back several times. Update your risk by member as well as your quality by member to be able to have transparency in giving this information to your provider so they have something concrete to work with. So really a case study here on an outreach program. Had a health plan that didn't have the resources to do outreach to all their members with a RAF score less than 1, so they engaged us to do an outreach similar to what we do for hospital inpatient data capture. There was an incentive paid to PCPs, consistent follow-up with physician's office and members coordinating the visit. There were 41% of the members on the outreach list had completed the wellness visit, thereby enabling the closure of HCC and quality gaps. So the result in outcome for the plan was quite a bit of uplift in both of their programs. And so fostering collaborative partnerships. Now, what we mean by that is if you work together with your provider community, you will foster better outcomes. If everybody's reading off the same page, you will foster better outcomes. So from a provider-payer collaboration, everyone's asking the same question. Did I get paid correctly? Did I get all the data I needed? Did CMS get all that information? And ideally, a provider needs to have a view of both their side of the house, which they do, and CMS's risk score based on the RAPs and the EDPS. So there should be a process in place to share this information, have a feedback loop, encourage collaboration, and investigate without finger pointing. When the providers and the plans are looking at the same data, it's amazing how much can be achieved. We're going to follow this up just another little example of how powerful this is. We shared plan information with a provider group at the plan's request. There was a lot of data missing, but we had every bit of data the health plan had. Turns out there was a disconnect between the plan and the provider, and until the provider saw how little data CMS had, nobody knew that was missing. We were able to recover $7 million for the health plan and then the commensurate percent to the provider with 3 hours of effort. And that is a true story. And that is just one example of many. $10 million in 90 days, all because you're fostering transparency and collaboration. Providers are really the only ones that understand who they've seen and what data CMS should have. So having an integrated platform that supports not only a range of providers, but also a range of health plans. So let's just say you're new to risk adjustment, you need in-service and education, you need some help outsourcing patient or provider engagement, or you want to make sure you're both looking at the same list by going off shared suspect lists. You want to see what CMS knows to be true. If that doesn't equal what you know to be true as a provider, then you need to get together with your plan and find out why not. So having one tool to support all this on one platform, irrespective of, if you're a provider, irrespective of how many plans you have, they're all in one, or if you're a plan, irrespective of how many contracts you have across the country, they're in one, and you can look at it all with one look and feel. But from a quality standpoint, from a care standpoint, from a revenue standpoint, increasing one increases the other. Working together is always better than working alone or in a silo, because we're going to sink or swim it as an industry, not as an individual entity. Some of the analytics that would drive engagement, if you're able to give a tool such as this, a health assessment tool to your provider, on the top part it shows all the dates of service that they've been seen for their risk adjustable. If you'll note that not HP, you can see what someone came to your health plan or provider group with that you didn't send it with. And if you note, they came with that the diabetes in 14 data service, but it got covered in 15 because they were actually seen. And in the second part, you are able to see deficiencies or what they need to be seen for the quality measures when they're in front of the physician. So it never hurts. You know, it takes a village is a true statement no matter what arena that you're in. Here's another example, another case study, a 65,000 member health plan. They wanted to improve the risk scores. They wanted to deliver actionable information to the providers in a consistent format. They wanted to identify, of course, members with gaps in chronic conditions that once acquired don't go away, your COPDs, your CHFs, your quads, your paras, things like that. They also wanted to understand low-performing providers. And when you say low-performing, you don't mean their performance necessarily in patient care is low. What you mean is the data reflecting that care is low. They may be the most outstanding provider you have, but if there's a problem with the data getting to you, then they look like their members are healthy when they're actually not, and they are doing the work. So this particular provider took a three-pronged approach. They provided software for high-volume providers, their 10 highest volume providers, identified super users in the group, and they provided the kind of transparency. They were able to use this, the health assessment form, and they were able to engage all members on a monthly basis. And in doing this, they were able to close gaps. They had $24 million a month in gaps when they started. They closed enough gaps, 38%, within a short period of time, i.e. 6 months, to successfully realize $9 million a month in additional reimbursements. So having this kind of information is critical. We all depend on each other. We need to start collaborating and understanding that each person's success, each entity's success is a success for the industry. And I'm probably preaching to the choir if you're on this call. And it doesn't have to be a big change to carry significant revenue implications. So using our application, within 90 days, this particular health plan was able to change their risk score by 0.03, from 0.95 to 0.98, which is $24 PMPM. The consequence of that was that $12.9 million more to the health plan, and at a 35% rate, $4.5 million more to the provider. Now, it didn't take long. If you know where to look, you can find the rock and overturn it, and you'll see what you get from underneath it. So, so with that, let's all take a breath and go ahead, Sean.
Thank you, Pam. We'll now be entering our question and answer portion of the webinar. So as a reminder, please submit any questions using the questions window on the right-hand side of your screen. We also, when people registered for the webinar, asked if they had any questions. So while people are getting in their questions from the live audience, let's go ahead and start with those. So question here, as far as resources to find updated ICD-10 to HCC mapping. So is there a source of truth that we can point folks towards?
Yes, I believe CMS just released a new roll-up on December 30th, and it's under the rates and statistics on the Medicare or the CMS.gov website under Medicare.
Okay. Second question here is, how is encounter data different from episode data, and are there any pilot projects rolled out to evaluate its effectiveness?
So encounter data is an encounter or a visit with your physician or the hospital visit. It is an occurrence. Episodic data is a series of occurrences for treatment of some sort of an episode of illness. So, and I'm not aware of any pilots on that. There may be, but unfortunately, I'm not aware of any that I could talk to today.
Okay. We have a question here. I've heard a few speakers recently refer to gray codes, diagnoses that are filtered from RAPS but are risk adjusted for EDPS. I'm not sure what the question exactly is for me.
Okay, I haven't heard of the term gray codes, to be honest with you. But if they're filtered from RAPS, meaning they're not included in RAPS but are on the EDPS side as filtering through on an MAO 004, that could be the result of the using specialty on the plan side and not on CMS's side.
Okay. Another question here is it's asking your thoughts on AHIP pushing back on the use of encounter data.
Well, I think that we all should support them in doing that. I have heard several times that they are working on that position. We don't really have any concrete information other than what we got this month for the additive from 14 days of service. MAO4s aren't correct, so you can't correctly predict what your revenue is going to be, and that's really hard to place your bids when you don't know really what your revenue will look like. So I would support anyone supporting that pushback on them.
Okay. Question here on one best suggestion for EDPS. So you covered a lot of different sort of things that can be done.
One best suggestion?
So, but one best suggestion for handling the EDPS blend and increase that.
I would suggest that you treat, we mentioned it in the webinar, that you treat your encounter data with the same amount of detail, attention, and importance as a fee-for-service claim, because in essence it will become that, especially when and if they use it for recalibration or trying to just figure out what the costs are in our industry versus the fee-for-service industry. So I would, many people, they have somebody doing fee-for-service, make sure all the edits are passed, etc., and that all the CPT codes are as robust as they can be based on the documentation. I would suggest we use the same sort of emphasis on our encounter data. That would be my one best.
Okay. And then one question here around the national and local requirements for CPT and diagnostic billing. So should these strict edits be applied to Medicare Advantage billing as well?
I would think that they would. Now, they may not need them. MA plans may not need them to pay the claim. But CMS is imposing CCI edits. I have to say I don't know, national and local determinations. I don't know if CMS is that strict. The companion guides would tell you that. Haven't had that discussions on the user groups, and there is a user group in 5 minutes in case anybody, CMS EDPS user group. But I have not heard them talk at that level on CPT. But before we go to another question, I don't know if there's another one, but one thing I just wanted to leave people with, to survive you must be adaptable, and one thing Gorman said is vision without execution is hallucination. And Jeff Grant at the conference, ICE conference, said that he's been through several administrations, and his advice was don't alter your business plans. There will be time, you'll have time to react to the new realities once they take place. That was his parting words last month, so he's been around a lot of administrations, so we'll see what happens there.
Great. Well, by my clock, we are approaching the top of the hour, so I just want to conclude by thanking both Pam and our audience for joining us today to talk through today's topics. If you'd like anyone from CO to contact you about what you've seen today, you can visit us at the Contact Us page on our website. And just as a reminder, today's session was recorded and will be sent with a follow-up email in the next few days, probably early next week when we get it up onto our website. And with that, ladies and gentlemen, this concludes today's conference. Thank you again for your participation and have a great rest of your day.